Good morning again, everybody. It's Dr. Anthony Levinson for DeGroot Pain HQ. Before we get started with our special guest this morning, I thought this might be also a brief opportunity to provide a bit of an overview of the DeGroot Pain HQ resource. So some of you may be familiar, but painhq.org offers patients and their families access to free resources related to neuropathic pain. The webinar series that today's presentation is a part of is just one of the resources that you can access through the PainHQ website. And that includes a knowledge base, a series of e-learning videos, resources, as well as an opportunity to hear patient stories through our blog, as well as access expert evidence. So it's a real pleasure for us at McMaster University to provide the DeGroot Pain HQ resource for those of you and your families living with neuropathic pain. And it's also our pleasure to introduce this webinar series with one of the leading experts on neuropathic pain, Dr. Dwight Moulin. So I'm pleased to welcome Dr. Dwight Moulin from Western. He's a professor in the departments of Neurological Sciences and Oncology. He has chaired the Neuropathic Pain Special Interest Group of the Canadian Pain Society since 2005. He's also led the development of the consensus statement on the pharmacologic management of chronic neuropathic pain. That was first published in 2007. Dr. Moulin's also published and edited one of the seminal textbooks on neuropathic pain, and is also working with some of our McMaster researchers on best evidence approaches to neuropathic pain, very challenging conditions to treat. Today, he's going to be speaking about recent advances in the management of neuropathic pain, and we're also hoping to have time for some questions at the end of the presentation. For now, I'm going to turn it over to Dr. Moulin, and again, thank you so much for joining us today.
Well, thank you, Anthony, and good morning to you all. I'm very pleased to discuss with you what neuropathic pain or nerve pain is all about, and what we can do to help manage this condition. Most of the time we can help patients who have nerve pain, and I hope that this session is useful to you, and we will make sure to provide ample time for questions and discussion after the end of the formal presentation. So I will start with the second slide, and I will try and explain things very carefully. Some of the language on the slides is more technical, but I will try and explain this as clearly as possible, and I hope that the information is of value to you. So a good place to start is to think about what is neuropathic pain. And neuropathic pain is a word meant to indicate damage to the nervous system. And there are two parts to the nervous system. There's the central nervous system, and the central nervous system includes the brain and the spinal cord, and damage to the brain or spinal cord can produce nerve pain or neuropathic pain. And there are examples of how this might occur. So somebody who has a stroke in the brain, and this is unusual, but it can be particularly severe type of pain. If somebody has a stroke in the brain, that can cause nerve pain to occur. Damage to the spinal cord can also produce nerve pain in the arms and legs, and this can be after, say, a serious fall where there's damage to the spinal cord and even enough damage to cause the patient to lose function in their legs, or less severe forms of damage. And in our part of the world where multiple sclerosis is particularly common, it's common in patients with multiple sclerosis to have inflammation in the spinal cord, which can produce nerve pain in the arms and legs. So this is what we call central neuropathic pain, or pain due to damage to either the brain or the spinal cord. That only accounts for about 10% of patients who have nerve pain. 90% of patients who have nerve pain have it on the basis of damage to the peripheral nervous system. And the peripheral nervous system involves all the nerves that come off the brain into the face or off the spinal cord into the trunk or into the arms or legs. So all these peripheral nerves that go to the face or to the arms or legs can also be damaged, and this is a much more common type of pain due to nerve injury or neuropathic pain, and we'll discuss some of those examples on the next slide. So just to put this in perspective, this is to give you an idea of how common nerve pain or neuropathic pain is. It's present in 5 to 7% of the general population. So it is actually much less common than the other major kind of pain, which is due to, say, headache or people with back pain or neck pain. Those actually are far more common types of pain. Headaches and neck and back pain account for the great majority of people who have chronic pain, but up to 7% of the general population have pain due to nerve injury, and this can be a particularly difficult type of pain to control. But fortunately, we have drugs and other agents that can be very useful to manage pain due to nerve injury. So, what are the common types of pain that we see after nerve injury? Well, one of them that some of you may even that you may be very much aware of or even be troubled by is pain after shingles. So shingles is fairly common. About 1 person in 3 gets shingles, especially over the age of 50. And the other word for shingles is this herpes zoster. And over the age of 50, the pain can persist. Normally, when people get shingles, they might have bad pain when the rash breaks out. And this is the same. The rash is due to the same virus that causes chickenpox in kids. And when this rash breaks out, individuals will have pain, sometimes even before the rash comes out for a few days, and then they get pain with the development of the rash. And the rash lasts maybe 2 or 3 weeks, and as the rash goes away, the pain goes away. But in people over the age of 50, 25% or to 50% will have lingering pain for 3 months or longer, and a small number will even have pain at the 1-year mark, and then a small percentage of those patients will go on to have persistent pain. And I'll give you an example shortly of an individual who is still suffering from that kind of pain. Another common type of pain that produces nerve injury is pain after surgery, because when surgery is done, nerves have to be cut, and those cut nerve endings get irritated and can cause the pain to persist. And one example of that is pain after breast surgery. So breast surgery cuts nerves that go to the chest and to the armpit area, and 20 to 30% of mainly women after breast surgery will have persistent pain that we refer to as post-mastectomy pain. The other common cause of pain after nerve injury is pain following the development of diabetes. And so people with long-standing diabetes carry a risk of having nerve pain as a result of that nerve damage. And the better the diabetes is controlled, the less likely they are to develop further nerve damage. And the pain due to diabetes is pain typically in the hands and feet, and it's usually worse. In the feet. And so these are some of the common causes of nerve pain. There are many others, but these are the main ones. And we'll go on to the next slide. It's important to remember also that nerve pain or neuropathic pain can coexist with what we call a nociceptive pain. And nociceptive pain refers to injury to the body itself. So this is the muscles or the bones or ligaments and tendons in our bodies. And some people have a combination of both nerve pain or neuropathic pain and this nociceptive pain, like chronic back pain. So another common cause of nerve pain is sciatica. So these are individuals who have had a disc protrusion or a ruptured disc, and then they get a pinched nerve with pain going down their leg. They might have surgery, but the surgery and the pinched nerve from the disc, slip disc, cause scar tissue on the nerve. And so these are individuals who have chronic back pain and lingering pain, usually down the leg, as a result of scarring of the nerve. And so they have a combination of both nerve pain from sciatica and back pain from the degenerative arthritis in their spine. And 7% of patients with low back pain will have lingering sciatica. And so sometimes we have to remember that individuals have both nerve pain and, say, chronic back pain. Next slide. So this is an example of a patient that I've seen who has kindly allowed me to tell her story. This is a lady who developed this horrible rash in her left forehead, and she had severe pain in the forehead and into her nose and on the inside of her left eye. And this is the rash of shingles. And so shingles can develop at any age, but as I said, about a third of the population will get shingles in their lifetime, and she developed shingles in the left forehead region. I didn't see her at that time, but she was smart enough to take a picture of herself when she developed the shingles, which is very helpful because it makes us realize how much nerve damage can occur as a result of shingles. I actually saw her 2 years after she had the rash from shingles because she still had horrible pain in the left forehead. And if you go to the next slide, you can see that 2 years later, you know, this lady, a delightful lady, she wasn't difficult to manage in any way. She just had this horrible pain in the left forehead region, and you'd never know it looking at her as she appeared 2 years later because the skin has healed, but there's still that nerve damage underneath the skin. So we have to recognize that individuals can be complaining of severe pain and look perfectly normal, and pain is totally subjective, so we have to be aware of that and validate the pain and recognize that pain is exactly what patients say it is. And she had this severe pain in this area. And patients with nerve pain describe their pain in a very distinctive way. And we'll go to the next slide to talk about that. Because these are the major features of pain due to nerve injury. And there's some medical words here, but basically when people have nerve pain, they say that the skin is burning or it's like it's on fire, as if somebody poured boiling oil on their skin. So the common words that are used is burning pain, and this lady had burning pain. And then they get, on top of that, they get stabbing electric shocks, or so-called lancinating pain. And she had that as well, with the steady burning pain in the left forehead, and then these sharp electric pains on top of that. And then the other feature of nerve pain is that the skin becomes extremely sensitive to light touch. Normally, a light touch of the skin is not painful at all, but people with nerve pain, light touch can produce severe pain. And even a wind, going outside, cold wind or breeze, or sometimes even air conditioning, can irritate the skin and produce severe pain. So these are the three common features of pain due to nerve injury. And when we hear these kinds of words, we can almost be certain that some kind of nerve injury has occurred. Next slide. We have to remember that when patients have chronic pain, and this isn't just individuals with nerve pain. It can be chronic back pain or headaches. You all know that this has many effects on the body and person beyond the pain itself. Chronic pain can impair function, so it makes people less mobile. It affects their sleep, and if you're not sleeping at night, we all know what it's like. If you don't sleep for several nights, you get irritable and you get tired, and it affects us in many other ways. So there's mood disturbance. People can get depressed and can get anxious. They can get irritable, and we actually have drugs that can combat both the nerve pain and some of these mood changes. There are also other complications of chronic pain that you're all familiar with. It includes interactions with family members can get strained. It can affect intimacy. It can prevent people from carrying out their usual recreational and social and fun activities. And it can cause loss of work and disability, and require these patients to see lots of doctors. Also there is a small risk in some of these individuals of going on to substance abuse because they are so stressed over their chronic pain. So we have to deal with all these other complaints in addition to the primary complaint of the nerve pain itself. Next slide. So this is a slide, just a diagram to help explain what is the nature of nerve pain and why it exists. And so this again is just what we call a peripheral nerve. You can think of this nerve ending as being, say, in the hand, and this is the nerve going up the arm into the spinal cord. And after nerve injury, when the nerve is damaged, there are these channels that we call sodium channels that are extremely irritable and form along a damaged nerve. And these sodium channels start firing electric shocks when they shouldn't. And those electric shocks and burning pain go into the spinal cord and then go up to the brain and register as pain. And so we have drugs that we use to combat irritable nerves. So basically, individuals who have nerve damage, some individuals with nerve damage, not everyone, but some individuals with nerve damage develop irritable nerves. And that's what neuropathic pain is. It's pain due to irritable nerves, and we're looking for drugs that dampen down these irritable nerves, including these abnormal sodium channels that form along nerves. And next slide. So what kinds of drugs do we have that are useful for managing nerve pain? Well, there are 5 categories of drugs that we use. We usually start with one drug, and it's all trial and error because everybody's different. Some people will respond to one drug and not another. In fact, some individuals we'll put them on one drug and then we have to add another or even a third one before we get their pain under control. And so one category of drugs that we use for nerve pain, you may be familiar with some of these names like gabapentin and pregabalin. This is in the class of anticonvulsant type drugs. And anticonvulsant drugs dampen down irritable nerves. They're commonly used to treat epilepsy because epilepsy is a condition where there are irritable nerves in the brain that can result in convulsions. But anticonvulsants, and in particular gabapentin and pregabalin, help to dampen down irritable nerves. The other category of drugs that we use for nerve pain are antidepressant type drugs. And some antidepressant type drugs are good painkillers. And these include what drugs we refer to as tricyclic antidepressants. An example of that would be amitriptyline. And then there are other drugs that are called SNRIs that are also useful for nerve pain. And an example of that would be duloxetine. And that's a drug that's advertised on TV frequently because duloxetine is a drug that is useful for nerve pain, but it's also used to treat depression and even arthritis. One other approach to nerve pain is to apply lidocaine, a patch, and that's applied directly to the area of nerve pain. And lidocaine is the same agent that a dentist would use to freeze our mouth to do dental work. That same agent, lidocaine, when it's applied to the skin, can block those sodium channels and can help to relieve pain. So somebody who has pain due to shingles can have this cream applied to the skin, and it can help to relieve the pain, and it's applied for 12 hours overnight. and it usually relieves pain the following day. One real advantage of applying lidocaine patch to the skin is that this is the only agent that produces virtually no side effects. It doesn't cause any nausea or drowsiness or any of those things that can occur with painkillers that are given by mouth. Stronger agents to treat nerve pain include the so-called narcotic type drugs, and there is a weak narcotic called tramadol, which can be useful for nerve pain, especially pain due to diabetes. And then there are stronger narcotic type drugs like morphine and hydromorphone and drugs of that type that we use for particularly severe pain. I'll just have you, next slide. So this is an example of another way of combating nerve pain. This looks like a complicated slide, but I'll explain it because I already talked about drugs that we might use to dampen down irritable nerves in the underneath the skin, and we can use that topical lidocaine or drugs that block those sodium channels. But what this represents is this is just a nerve coming in from, say, the arm or the leg and going into the spinal cord, and then that message gets carried up the spinal cord to the brain. But there's another class of drugs that I already mentioned, the group of drugs that are called antidepressant type drugs, and these are drugs that dampen down irritable nerves that are coming in from the arm or leg with the messages going up to the brain. So just next slide. And so what this is showing you now is that here are these nerve impulses coming from the damaged nerves in the arm or leg, and those messages are going into the spinal cord and then going up the opposite side of the spinal cord up to the brain. And there's this other set of nerves that's coming from the brain also, but it's coming down from the brain into the spinal cord. And when this is activated, and it's activated by antidepressant type drugs, these messages coming from the brain down this blue pathway interrupt these pain messages that are coming through so they don't get to the brain. So just click the next slide. And this pathway from the brain is actually this pathway here. So these antidepressant type drugs are coming down from the brain, and they block these pain impulses that are coming through so that the pain messages can't get through and go to the brain. So this is just another example of how a different type of drug, in this case antidepressants, block pain messages that are trying to get through from the arm or leg, and that's why some antidepressant type drugs are particularly strong painkillers. Next slide. And next one. And next slide again. So here are examples of some of the side effects from some of the antidepressants that we use, and some of these names may be familiar to you. These are the class of tricyclic antidepressants, so drugs like amitriptyline and nortriptyline. They can cause drowsiness or sedation. Anticholinergic side effects refer to it can produce a dry mouth. They can lower blood pressure. They can cause irregularities of the heart. Rarely they can even produce convulsions, and they can produce weight gain. So some of the antidepressant type drugs, these so-called tricyclic antidepressants, can be very good for pain, but they can have side effects. We tend to use this one, this nortriptyline, because it doesn't produce as many side effects as amitriptyline, but it can still cause some drowsiness and dry mouth, and weight gain can still be a problem. And most people are not happy if they're gaining weight from the drugs that they're using, but some of these drugs help people to sleep at night as well and can be useful for nerve pain. Next slide. So here's the list of all the types of side effects that these drugs can produce. I already talked about the effects of the tricyclic antidepressant, but these are the anticonvulsants, and these are some of the other antidepressants and narcotic type drugs. And basically anything that's used for pain as a pill can make people drowsy or dizzy or cause weight gain or constipation. And so we have to be aware of all these side effects. And sometimes people will say, well, this drug is relieving my pain, but I'm just too dopey, I can't function. And if that's the case, we have to move on to a different drug that might be useful for their pain. Next slide. For people with particularly severe pain, we might move on to use a so-called strong painkiller or a narcotic type drug. And what we are hoping for when we use a narcotic like morphine is that it'll provide pain relief and relieve the anxiety that occurs with pain. But we have to be careful when we use narcotic type drugs for pain. Rarely it can affect breathing, and it can still cause drowsiness or nausea. We can usually treat that. It can cause constipation, and patients need to go on a medications to keep their bowels moving. One thing that's really important to recognize about using narcotic type drugs that we refer to as opioid analgesics is that if somebody goes on a narcotic type drug for any type of pain and they're on it for more than 2 weeks, you can't stop it suddenly, because if you stop it suddenly, then patients have what we call a withdrawal reaction, and they'll get shaky and get sweaty and can cause diarrhea. And that's a reaction that occurs in anybody put on a narcotic type drug for more than 2 weeks. That is not addiction. That has nothing to do with addiction. It's just some drugs you can't stop cold turkey. And so we have to recognize that has nothing to do with addiction, but we have to be careful in patients that we put on a narcotic type drug because some of these patients, if they're coping poorly, can develop addiction, which is craving for the drug above and beyond need for pain control and continuing to abuse these types of drugs despite ongoing harm. So we have to be very careful about distinguishing physical dependence, which is this withdrawal reaction, from psychological dependence or addiction. Next slide. One other type of drug that you might hear about that can be useful for nerve pain is methadone. Methadone is a narcotic type drug. Most people are aware of methadone being used to treat people who do have a problem with addiction because it decreases the craving for heroin and other drugs of that type. And so there are methadone clinics all over Canada and the United States to treat individuals who have problems with addiction. But methadone, despite being used to treat addiction in itself, is a powerful drug that can sometimes be useful for nerve pain. So we will give patients methadone when other things haven't worked to treat their nerve pain, and we're not treating addiction, we're treating their nerve pain. And methadone has some special properties that I won't go into that are specific for damping down irritable nerves. So sometimes we will use methadone when all these other drugs haven't worked, or other narcotic type drugs like morphine or a morphine patch haven't worked. And so this is just something to be aware of because it can be useful for nerve pain. Next slide. So this is an example of a study we published 10 years ago now, and this was patients that I'd followed, about 50 patients with particularly bad nerve pain that I've been following for years, and half of them we call the success group because it's really worked well for them, and the other half didn't do so well. But half of these patients who had particularly bad nerve pain did well on methadone, and I'm still following many of these patients. Next slide. One other area that I want to talk about, it's very topical now because there's a lot of stuff in the media and TV and newspapers about marijuana. And endocannabinoid is just a fancy word for marijuana type drugs. And there are specific receptors in the nervous system that respond to marijuana type drugs. And so the main message here is that marijuana, which comes from the plant, and it can be either smoked or inhaled or even eaten, ingested, we have very good evidence now that marijuana or marijuana type drugs are good painkillers. And we do use them when other things fail. And this can be taken either by smoking it, which can cause some lung damage, or it can be used in a vaporizer at room temperature and inhaled, where there is much less risk of any lung damage. And we also have synthetic marijuana pills, pills that like Nabilone, that are particularly useful for nerve pain. So the main message here is that marijuana, again, although it's a recreational drug for some people and they use it to relax and as a drug that makes people feel good in other ways, marijuana is definitely a painkiller, and it can be particularly useful for nerve pain. And the rules about medical marijuana have changed in the past year or two because the government no longer provides marijuana. It has to come from a drug company, and the result of this is that the cost of marijuana has doubled. And so what might have previously cost a patient $200 a month for marijuana, the cost has doubled now to $400 or $600 a month. It's not covered by any drug plan. Marijuana can be a useful drug, although it can cause drowsiness and making people feel lethargic. It's also become quite expensive. Next slide. And here's another example of a marijuana type drug that's available in a spray that it's available through standard pharmacies, and it's a spray in the mouth that they can use several times a day. And this is approved particularly for pain due to MS or multiple sclerosis. Unfortunately, this particular type of marijuana as a spray can be effective, but it's very expensive and you need a good drug plan. It's not covered by provincial drug plans, and it can cost around $500 a month for this spray, which can be particularly effective for nerve pain. Next slide. So how do we treat individuals who have nerve pain? We've talked about all the drugs that we use. So here's our lady again who has the severe nerve pain involving her left forehead. And what can we do for somebody like that who has nerve pain due to shingles or diabetes or after surgery or after MS? And so we have a recipe that we use based on scientific studies that have been done to help us know what drug to use first, what drug to use second, and sometimes we need to use a combination of drugs, and we'll see this on the next slide. So here's our what we call an algorithm. It's a stepwise approach to the management of nerve pain, and we published this in 2007, but we just did an update late last year, so it's sort of hot off the press. And so the first line drugs that we use for nerve pain are these various antidepressants. I talked about the tricyclic antidepressants, or these SNRIs, which includes duloxetine, and the other are the anticonvulsants. We talked about pregabalin and gabapentin. So we would pick one of these drugs, and we don't have any evidence that any one is better than another, so your doctor can start with a tricyclic antidepressant type drug like nortriptyline, or pregabalin or gabapentin, or something like duloxetine. And important to remember that especially the antidepressant type drugs can take a month to work. So I always say to patients when they go on one of these drugs, don't give up on it and stop taking it. It can take a month before it might kick in. So you have to persevere for at least a month before you might know what the benefit is going to be. And some patients only get partial relief with one of these drugs, and then a second line drug we use would be a weak narcotic like tramadol, or a stronger narcotic like morphine or morphine patch. And if we're still not getting enough relief, then we might go on to a marijuana derivative as a third line agent. And then if that doesn't work, we might even go on to other agents which include other anticonvulsants and also the methadone, which I described before. What isn't in this recipe is to recognize that this topical lidocaine or patch that freezes the skin is particularly useful for pain due to shingles. And as I said before, some patients will be put on a first-line drug and they get some relief. Then we have to add a narcotic type drug, and then we might even have to add a marijuana type drug on top of that. And so sometimes patients will need 2 or 3 drugs before they get enough relief, and we just have to monitor them carefully that we're not making them too drowsy or produce other side effects that don't allow patients to function. So using one of these drugs or a combination of drugs, what our goal is not to eliminate the pain, because these drugs unfortunately never do that. We try and get the pain below a level of 5 out of 10. So if 0 is no pain and 10 is the worst pain you can imagine, we like to get rid of severe pain, 10 out of 10 pain, and we try to get the pain below a 5 out of 10, whatever that means to the patient. And that might be a 2 or a 3 or a 4. The goal is never to get the pain eliminated, because right now we don't have drugs or treatments that eliminate the pain completely, but we try and get the pain below a level of 5 out of 10. And so these are simple agents that any doctor can use to manage nerve pain. And next slide. So what do we do when simple medications by mouth or a patch don't work? Well, there are other things that we can do for nerve pain that are more complicated. All the things I've talked about so far, any doctor, any family doctor or specialist can prescribe those drugs. But if the drugs don't work, there are other things that we can do. But that means being referred to a pain clinic of some type for treatments that for specific treatments for pain that's particularly severe. And so I've outlined some of them. One of them is nerve blocks. And so this first line, lidocaine and steroid injections, if a nerve is being pinched by scar tissue, a doctor can inject the damaged nerve directly with lidocaine and with the steroid, and that sometimes gives good relief. Also, this drug that dentists use, this lidocaine, can be put in an intravenous infusion. Goes to the whole body, but also dampens down irritable nerves wherever that nerve injury has occurred. And some individuals will come into the pain clinic every month or two, every couple of months, and have an intravenous IV lidocaine infusion. And then there are other nerve blocks that can be done for nerve pain, including blocking the sympathetic nervous system or injecting steroids into the back for sciatica due to pain due to scarring of nerves after back surgery. And the other thing that we do for particularly severe pain is something called spinal cord stimulation, where we will refer patients to one of our neurosurgeons, and they have an electrical wire that actually stimulates the spinal cord, and the patient feels tingling, say down the leg in the area of their pain, and that tingling blocks the pain impulses from getting through. And so this is an electric wire that stimulates the spinal cord. It's attached to a battery like a pacemaker under the skin, and can be controlled by an external device, and that tingling can help to relieve pain. So these are some of the things that we do when pills and patches don't work. Next slide. And what else can we do to provide nerve pain? Well, one of the things that's available to actually prevent a common form of nerve pain, you may know that there's a vaccine available now. You can be vaccinated to prevent shingles. It's the same type of vaccine that's used in kitties who have to prevent chickenpox, but it's much stronger. In fact, it's 14 times stronger in adults. So there's actually a vaccination that can be done to prevent shingles from occurring. And we recommend this for everyone over the age of 60. The downside is that this vaccine is about $150. It is covered by some drug plans, but not by the provincial drug plan. And then there are lots of newer drugs that are being studied in scientific trials, and hopefully in the future we're going to have more drugs that are more effective with less side effects for nerve pain. But even the agents that we have now, we can usually provide reasonable relief, not complete pain relief, but get the pain under control with the agents that we have available now for nerve pain. So I think that's all I'm going to say, but I of course want to leave some time for questions, and if you have questions, please pass them along, and I'll try to answer them as best I can.
Thank you very much, Dr. Moulin. Very, very informative, broad overview of a complex topic, so very much appreciate you providing your expertise today. Anybody who has questions, the platform itself has been updated recently, so the chat pod looks a little bit different and more contemporary, but there is the little bubble on the side panel of the webinar platform, and you can type in your questions and send that message along if you have any questions. I'll maybe use my prerogative to throw out some questions while waiting to see if anyone else has any. But maybe you could just comment a little bit in your experience, Dr. Moulin. How often are you usually able to manage some of the pain symptoms with a single agent versus the sort of trial and error of combination therapies?
So that is a very good question, because we recognize that if we have to add a second or third drug, there's the risk of more side effects. And often questions like this, we use the word it depends, because it depends on the setting. So family doctors who see their patients early on, somebody who develops pain after shingles, or they've got pain from, say, diabetes, when family doctors see these patients and they've only had the pain for, say, a month or two, and the pain hasn't become particularly severe, if family doctors start these types of drugs earlier on, it can prevent the pain from getting worse and might be more effective. So for family doctors, it's fairly common that just one of these drugs can get the pain under a level of 5 out of 10 if they're seen early. So they might only need a single agent, whether it's an antidepressant or one of these anticonvulsant type drugs. By the time they get to our pain clinic, and these are the patients that have more difficult to treat pain, by the time we see patients in our pain clinic here in London, Ontario, most patients have had pain for an average of 5 years. So they've had the pain for a long time, and they're just the individuals who've had particularly bad or intractable pain. So our patients, because they're more difficult to manage, it's common for our patients to require treating them with 2 drugs or sometimes even 3 drugs. But for family doctors who would see these patients earlier on, 1 drug may be enough, and that means fewer side effects.
One of the other things that I've noticed in my practice, which again is also a bit specialized, I work in medical psychiatry and also work in a neuropsychiatry clinic. From one of the things that I've seen, it can sometimes be quite challenging to get an accurate diagnosis, and I'm just wondering if that's one of the things that you've noticed. You mentioned that sometimes people have suffered from pain for several years before referral to your clinic, but in my experience sometimes people don't have an accurate diagnosis of neuropathic pain, and so they aren't always managed even with some of those agents like gabapentinoids or the sort of first-line agents for neuropathic pain. And I was wondering if you could comment on that as well.
Well, that also that can be very challenging. The good news is that we found over the past few years, maybe because of a lot of the training in medical school and also educational events for physicians in practice, is that most family doctors now recognize nerve pain due to diabetes, because this burning pains in the hands and feet, and they recognize nerve pain following shingles, and those are usually recognized, and many of those patients will get an appropriate agent. But what isn't what isn't recognized as well, and in fact types of pain that are even more common than those, is sciatica. Sciatica is even after people who've had surgery that didn't give them good relief because they've got scar tissue on the nerves. Individuals who have chronic back pain and sciatica, that burning pain down their leg often doesn't get recognized as being a nerve pain, and some of those patients will wait a long time to get appropriate treatment. And there are other forms of nerve pain, say pain after surgery where these nerves are cut. Some of these individuals are not recognized as having nerve pain after surgery, and they can wait, unfortunately, quite a while before they might get their pain treated. So there's still education that's required to make more people aware of nerve pain, and less common. It's still not well recognized that patients with multiple sclerosis, half of them have nerve pain, and sometimes they wait a long time before it gets diagnosed as well.
Well, your comments, we've got a couple of questions coming in the chat panel, and one of them ties in with something you were just talking about in terms of back pain and sciatica. So one of the questions is that if you've got nerve pain due to a bulging disc, but it is not necessarily severe enough to go to surgery yet, there doesn't seem to be a lot of great information out there in terms of management, or I guess just information generally. Do you have any thoughts or recommendations around that particular situation?
Yes, so this is a very common problem, and as we get older, our discs, which support our back, can crack, and when a disc cracks, the material inside can come out as what we call a bulging disc, and that can pinch a nerve down the arm or leg, and that is a form of nerve pain. And not all pinched nerves require surgery. In fact, it's only a minority, probably less than 1 in 10%, that need to go on to surgery, because when discs bulge like that, the material comes out and then it dries up. And so for many of these patients, they need just to have their pain managed for what might be 2 or 3 months to get the pain, keep their pain under control until the pain goes away on its own, because pain from pinched nerves due to bulging discs very commonly, fortunately, gets better on its own. So somebody who has severe pain from, say, sciatica, from a bulging disc and pinched nerve needs to be given one of the medications that we talked about. It could be one of the anticonvulsant type drugs, but often these patients, because they can have severe pain, will need a straight narcotic type drug. It could be Tylenol with codeine, or a Tylenol number 3, or it could be oxycodone, a stronger drug that we sometimes use, like Percocet. So somebody who has a sudden severe pain due to a pinched nerve, say sciatica, still would benefit from these types of drugs just to get them through the most severe pain. But we always tell these patients too to still be as active as they can be, because rest is not good, and the more active they can be, the more quickly they're going to recover, and sometimes physiotherapy can help as well.
That's great. One of the other questions that came in, which we've been talking around that issue, is, how long does neuropathic pain last, and does it ever go away by itself? Does it change over time? And I think you've sort of addressed that one. It depends on the cause of it, because sounds like in some cases where the cause is related to a bulging disc, it may well alter over time, but there's going to be other situations where, if the cause is related to herpes zoster or multiple sclerosis or post-stroke, the nature of the change over time might be quite different.
And yes, and that's true. So the good news is that pain due to a pinched nerve from a bulging disc, that usually gets better on its own. And even other kinds of nerve pain, and the best example we have of that is nerve pain from shingles. The good news is that people who get shingles over the age of 50 are at risk of the pain persisting even after the rash goes away. But the good news is that when these patients are followed for 1 or 2 years, for many of these patients, the pain still goes away over the coming months, so that at the 1-year mark and at the 2-year mark, only about 5% of these patients still have pain. And so the rule of thumb that we use for pain after nerve injury is that it usually gets better for most people in the months following the nerve injury, but if they have it at the 2-year mark, because nerves do heal, but they heal very slowly. If the pain is there at the 2-year mark, no matter what it's due to, it probably is not going to go away on its own, and it's going to need to be managed in the long term.
Well, thank you very much, Dr. Moulin. We've pretty much come to the end of the hour. Again, very informative. Thank you very much, everybody, for participating and sending in your questions as well. Encourage everybody to check out the group Pain HQ, learn, connect, get involved. We've got information in the knowledge base. We have some instructional videos as well, and there's an opportunity to connect and tell your story, review the blog. We do also have access to other evidence-based resources, and again, there'll be additional webinars in the future. So again, our thanks to Dr. Moulin for today's webinar, and thank you all for joining us today.
And thank you. I've enjoyed talking about nerve pain. It's one of my favorite subjects, and I hope everybody benefited from the discussion, and thanks for your questions.